Great. Okay, cool. I'm off to a strong start. Well, welcome everybody. Happy New Year. I'm Lucy Wilkening. I'm going to talk today about best practices in ambulatory alcohol detoxification. A lot of this is going to be background information, so you may be familiar with some of it, but I noticed over the past few months that I have gotten quite a few questions about alcohol detoxification, so I thought it would be a good idea just to go over some of the best practices. There is a lot of clinical art in managing alcohol withdrawal, and there's a lot of nuance. But I'm going to try to cover the things that I think are the important kind of clinical pearls to remember when doing this. I also want to give a disclaimer that this is not a discussion on inpatient alcohol detoxification, which is it's got some similarities, but it's distinct and different in its own ways. So, our goals for today, we want to describe, I'm going to call it AM detox, ambulatory detox, and its role in managing alcohol use disorder. We're going to talk about identifying appropriate patients for ambulatory detox. We're going to talk about some common protocols and medications. And again, this is where there's a little bit of nuance and variability from clinic to clinic and provider to provider. But I'm going to again talk about some of the fundamentals here. And then we're also going to talk about some of the risks, limitations, and safety considerations when we are specifically managing somebody on an outpatient basis for alcohol withdrawal. Let's start with what alcohol is. And I want to be really clear. There's no recommended amount of alcohol that is healthy for you. Okay. Alcohol is a CNS depressant. And it has some interesting pharmacology. And it's kind of got a 1-2 punch when you think about its CNS depressing effects, the kind of dampening effects it has on the central nervous system. So on one hand, it has this kind of down regulating, and for those of you who haven't had to sit through a pharmacology course, that means it kind of makes the system lazier, right? So it kind of down regulates the inhibitory part of our brain, right? And it also simultaneously causes the excitatory part of our brain to have to work really hard to balance out the addition of another CNS depressant like alcohol. Okay, so these two things combined result in a significant CNS depressing effect, which is why if you look in the data amongst people who have died from overdoses, alcohol is frequently involved, right? It's interesting when you really read about the pharmacology of drugs like benzodiazepines, for example. So these are medications like lorazepam or diazepam. Overdoses from those types of medications by themselves are actually extraordinarily rare. But when you mix in a drug like alcohol, there is an exponential increase in risk of overdose, right? Because of its CNS depressing effects. I would also remind you that CNS has alcohol has a disinhibiting effect as well, right? Which is why we also oftentimes see it involved in suicide cases. So it presents a lot of issues, and it is a CNS depressant. I will oftentimes remind my patients who are taking antidepressants, right, that if you're drinking at the same time as taking an antidepressant, that is the immediate and opposite effects of one another, right? What is a standard drink? This is something, especially non-medically trained folks, get confused on. Like, what constitutes a standard drink? And we actually have definitions for this for a variety of reasons, including conceptualizing somebody's risk with alcohol withdrawal, quantifying how much alcohol a person is consuming, and conducting clinical trials, right, to help us understand how different medications and different interventions can help with alcohol use disorder. So for the record, right, a standard drink would be 12 ounces of what patients would call a regular beer. So this is going to be something like Budweiser, for example, that has about a 5% weight by volume. This is equivalent to about 7 or 8 ounces of malt liquor, or if it's a person who's going to places like breweries where they're making craft beers, where the alcohol content is much higher, let's say like 6 or 7%, 8%, that is 7 to 8 ounces of that is equivalent to 12 ounces of what I'm going to call a regular beer, right? This is equivalent to 5 ounces of wine, which is equivalent to 1.5 ounces of hard liquor. So things like whiskey and tequila, right? So for example, if your patient is at the bar, right, and they order a double, right, that's two drinks, right, because there's 3 ounces of liquor in that, even though it comes in one glass. And this is a really critical it's very critical to quantify how much a person is drinking, especially as they are entering into alcohol withdrawal management, because it can really shift our approach and even if they are a candidate for outpatient detoxification at all. So having a clear grasp on what constitutes a standard drink and quantifying that with people as they come in for treatment is a really, really important part of the clinical history when you're working with somebody. The other kind of background that matters here is the frequency, the prevalence of alcohol use disorder and alcohol consumption globally, right? There's really no social situation in the United States where alcohol consumption is not normalized, right? We see people drinking alcohol at funerals and parties, right? Even in the hospital, we use alcohol for self-directed alcohol detoxification at some facilities, right? So this is something that's been normalized in a lot of different places. So use is really pervasive. And taking that a step further, as of data in 2024, 1 in 10 adults in the United States meets criteria for AUD within the past year. And amongst those people, around half will experience some degree of withdrawal when they stop or reduce use of alcohol. Once upon a time, when I was working inpatient, another population where you have to be very conscientious of this is folks who are incarcerated. Right. So we see a jump from around 3 to 4% of the general population where there's a risk of, alcohol use disorder and alcohol withdrawal. Amongst incarcerated individuals, there's about a 2 to 3 times increased risk in this group, right? Where even in my past hospital, when somebody arrived via police, this was an even more significant group where we're screening actively for things like alcohol intoxication and alcohol withdrawal. AUD is undertreated, right? Less than 10% of people within the past year receive any treatment, right? Even though we know that untreated or undertreated AUD significantly increases the risk of severe complications, alcohol withdrawal, and even things like delirium tremens. Um, one of the issues with alcohol withdrawal management is patients' reluctance to go to the hospital, right? That's one of the things that I have frequently encountered in practice. And on top of that, inpatient resources are limited and they're costly, right? I like to follow some of my neighborhood groups to see what people are talking about. And they're talking about here in the Treasure Valley going to the ER and they're waiting 3 or 4 hours to get in and people will leave, right? So there's a lot of layers to this onion as to why we need to be cognizant of ambulatory detox and offering it to folks, not only from patients, not going to receive treatment, but also the difficulty they can have with getting inpatient for treatment as well. And alcohol withdrawal is predictable. It's also preventable. And I remember when I was a resident, I had an attending who would always say it's easier to stay out than to get out, right? And he always say, Lucy, like you should think of alcohol detox the same way you think of pain, right? You should stay ahead of the curve. It's easier to keep people out of it than it is to get them out of it, especially when it's really severe. So what is alcohol withdrawal? It is a physiologic response to sudden reduction or cessation in alcohol use. That's the technical answer. What I always remind my students and my residents is drug withdrawal. What is drug withdrawal? It is the immediate and opposite effects of a drug that a person's been using, right? So if I've been drinking alcohol because I need it to help me fall asleep, right? Or it's helping me with anxiety or it's making me tired, right? When you see those patients present in alcohol withdrawal, you're going to see the opposite of those things, right? You're going to see increased anxiety. You're going to see insomnia. You're going to see autonomic instability and a host of other things. And what you also have to remember is the definition of CNS hyperexcitability, that's called a seizure, right? That's the other thing that's very serious here is when a person has been using alcohol, especially in a chronic manner, in a chronic heavy manner, when they are going through withdrawal, they are at increased risk for serious seizures and other things too, like delirium tremens, which is kind of the worst case scenario. So the CNS hyperexcitability that comes from alcohol withdrawal is really the target when we think about drug therapy and helping people manage alcohol withdrawal. Some of the signs and symptoms, I'm going to show you a timeline of what you can expect to see when somebody's presenting an alcohol withdrawal, and especially some of the warning signs. And again, it really is true that this can be fatal without proper management. So we've spent a lot of time last year talking about opioids, right? And how we manage opioid withdrawal. And in the case of opioid withdrawal, it's extraordinarily rare to see really mortality from that, right? You don't generally see people dying from opioid withdrawal because of its pharmacology, the pharmacology of opioids. But in the case of CNS depressants and hypnotics, like benzodiazepines and alcohol, this can be fatal if not managed properly. So it's really important that we do manage this properly. I also would encourage folks to conceptualize alcohol detox as risk mitigation, not just symptom relief. I I have oftentimes gotten questions and consultations about, well, what about, I have this patient, they're in withdrawal. I'm not sure what to do, but I also don't have labs. I don't have liver enzymes yet. And I'm like, yeah, I understand. And I'm so happy that you're thinking about drawing labs for somebody who's been drinking, right? But we're talking about risk mitigation in this moment where a person is undergoing something like alcohol withdrawal, which can be very serious. Um, and so we administer treatment and we really kind of need to put that on our scale of risk benefit and recognizing that we are in risk mitigation. A lot of times, especially when I worked inpatient, many people are, the horse is already out of the barn by the time they are in the ER, meaning they are already pretty symptomatic from alcohol withdrawal by the time they're in the emergency department. And so you need to act quickly to get them out of that, right? And so that you can have a smoother detoxification process. In the case of ambulatory detox, this should also be conceptualized as expanding access and improving continuity of care. Again, for either people who are reluctant to go inpatient or people who meet proper criteria for ambulatory detox. Again, but we should still be conceptualizing it as a risk mitigation, not just relieving symptoms. So what does alcohol withdrawal look like over time? And I do want to remind you, alcohol withdrawal doesn't only happen when somebody completely stops drinking. There are some folks who consume enough alcohol where to the point where even if they have a reduction in how much they are drinking, meaning they're still drinking at the time they're presenting to you, but they still have withdrawal symptoms. Okay. So it can include either completely stopping drinking or significantly cutting back on use that can cause a patient to manifest with these symptoms. And I'm thinking of a patient that I used to work with who would consistently come into the emergency department with blood alcohols in the 400s, which is very, very high, right? And by the time she was admitted, right, her blood alcohol content might fall to the 250s, 270s. But if you looked at her CWAS scores were very high. She was very, very sick, even though, for other folks, a blood alcohol of 250 or 270 would be intoxication. There are some people who have such a high degree of tolerance that even reductions in use can cause these symptoms. For the most part, common things being common, kind of the peak risk with alcohol withdrawal is over within about 48 to 72 hours. Okay, so kind of the thick and hard part of this is usually in the first 2 to 3 days. Now, I'm not saying that all the problems are gone after 2 to 3 days, and I'm also not saying that there aren't people out there who will have withdrawal symptoms that persist beyond that point because that would not be true. There are those folks that exist, especially if they're using benzodiazepines and alcohol at the same time. But common things being common, most of the time within 48 to 72 hours is kind of the worst part of alcohol withdrawal for most people. In the first 6 to 12 hours is generally after reduced use or cessation of use is when we start to see things like tremor, anxiety, nausea, and insomnia, and maybe some mild increases in heart rate and blood pressure. Once that patient kind of moves past that 12-hour mark is when we start to see some more significant impacts on their vital signs, right? So we'll start to see some increases in their heart rate. We'll start to see diaphoresis or sweating, blood pressure elevations, and worsening of the symptoms that they've been having, right? So they'll tell you, I'm feeling really anxious. I can't sleep. I can't sit still, restlessness. In the 24 to 48-hour period is where we really start to get concerned about things like seizures, significant amplifications of the symptoms that they have already been experiencing, and potentially even some mild hallucinations. And this is a really serious symptom, right? When you have a patient who's coming in who's got presence of hallucinations, especially things like visual hallucinations, those patients generally are not candidates for ambulatory detox, right? That is a symptom that could be indicating that you're entering into something like delirium tremens and they need an inpatient admission. Um, and then in the last 48 to 72 hours is where we start to see things that can potentially be fatal, like delirium tremens, which can have a mortality rate of up to like 35% if you haven't been managing this properly. So, I mean, I've been teaching for a while, and there's not many things that I can think of that have that high of a mortality risk without proper intervention. So, and to be clear, this is the crescendo of symptoms that will happen if you do nothing, right? Or if you are not treating the patient. The idea here is to prevent these symptoms from happening or to mitigate them as much as you can while also connecting the patient to other treatments that they need. Has anybody seen the blood alcohol impact table in the past when I've done like freshman orientations, right? And explained to people the impacts of alcohol? I want to point out a couple things here. This is the impact of alcohol in a person who does not have dependence or tolerance to alcohol, right? Meaning they don't have any kind of physiologic adaptation to alcohol. And also, by the way, on a breathalyzer, right, we say like the legal limit is 0.08, right? If you move that decimal to the right three places, that's the blood alcohol content, right? So a 0.08 on breathalyzer is an 80 if somebody were to check your blood. And there's magic that happens right in the lungs to help us do those calculations. But at any rate, so if I say an 80 on blood alcohol, what I mean is a 0.08 on breathalyzer. But you can see here, right, the kind of stepwise things that happen as a person becomes more and more intoxicated on alcohol. And I want to point out to you that in my experience of working with folks who have alcohol use disorder or an alcohol tolerance, I have seen people in the hospital and in the ambulatory detox center who will present with blood alcohols in the 200s, talking to me the way I'm talking to you right now, right? Which can really manifest, which really demonstrates significant tolerance. And this is another piece of kind of the art of alcohol withdrawal management, right? Is conceptualizing the amount of tolerance relative to what blood alcohol content is. And this is an important factor too in ambulatory detox for patients where you might say, I think it is better for me to refer this person inpatient based on the amount of tolerance that I'm observing on exam. So who is a candidate for for AM detox from alcohol? I want to say this too. Ambulatory detox is not a lower standard of care. We should not be thinking of it that way. It is a different level of care. And what I mean by that is manifested by who is a candidate for this, right? A person who generally has a stable home environment and support system. This is just as important as medical stability. And this is something that I have seen overlooked in my career from time to time. But it's important that there is stability and a place for a person to rest, just as if they were recovering from influenza, right? We need to have somewhere where they can rest and take the treatments that they're supposed to. Mild to moderate dependence is generally for those folks who have tolerance and dependence beyond moderate. They generally are better served with inpatient detoxification services. And I'm going to talk about how a few ways that you can kind of gauge the amount of dependence. Stable medical and psychiatric status. And I want to say this doesn't mean perfect medical and psychiatric status. Okay. It doesn't mean perfect. It means stable, right? Because generally speaking, when somebody is going through alcohol withdrawal, they're not going to sit and say, well, I feel great except for the alcohol withdrawal. That's not something that people say. What I mean by this, for example, from psychiatric status, right? We don't have any passive death wish or suicidal ideation. It's not a person who already experiences hallucinations at baseline as a component of their axis 1 disorder. Like, for example, something like schizophrenia, where it would make it difficult for you to interpret a CWAS score because of the presence of hallucinations on exam at baseline, right? So And also doesn't mean that medically the person has to be perfect. They may have something like diabetes or hypertension, but as long as it's reasonably medically stable, that is okay. Doesn't mean that they can't have medical comorbidities. It just means that they need to have medical stability. They should also have reasonable health literacy, meaning their ability to kind of adjust treatments, right, and adhere to a treatment plan is really important here. Who is not a good candidate for ambulatory detox. So any patient who presents and tells you that they have a history of withdrawal seizures, that is an automatic ticket to the emergency department. Same thing with delirium tremens because of the morbidity and mortality associated with this presentation. If I was forced to choose one um, risk factor on this list that I could present to y'all today, it would be the history of delirium tremens. Any patient who has a history of DTs, it's an automatic inpatient referral. Anyone who has a history of chronic heavy alcohol use, right? And it depends on, there are a few different definitions for this. Generally speaking, the one that I have used in my experience is five or more drinks on 5 or more days in the past 30 days is generally considered heavy use. Of course, I have seen patients who are using much more than that, and I've also seen patients who are doing kind of the opposite with like binge drinking. But nevertheless, any kind of chronic heavy use, especially chronic use that is concomitant with other drugs, especially benzodiazepines. In my own experience, I'll just tell you the cases that have presented the most difficulty have been patients who have heavy alcohol use combined with chronic benzodiazepine use. And generally speaking, those patients are best served inpatient where there are also ICU services available. Those can be, especially if the benzodiazepine use is also very high. Pregnancy, again, this is always considered medically, this is always considered problem number one, right? And in this case, when you have a pregnant patient, it's most appropriate for inpatient detoxification, untreated or symptomatic comorbid severe mental illness, or unstable medical problems, right? So, for example, if that patient has cardiovascular disease and their blood pressure is already reading at a very high level, right? That combined with alcohol withdrawal is it's just not super safe to manage that on an outpatient basis. The other thing that can present problems or complications or challenges, I guess is the best word, is withdrawal from numerous substances at once. And this is one where this is not, I wouldn't say this is an absolute, you can't ever do this on an ambulatory and an outpatient basis, but it is one that requires some thought, right? So if you have somebody who has been drinking alcohol and taking opioids at the same time, what do I do for those patients? Um, the textbook answer to this is generally if somebody is sick enough to the point that they are scoring on numerous withdrawal scales at once, they are generally best served inpatient. But there can be some nuance to this. And I welcome any comments or thoughts on that particular point. There are risk stratification tools to consider for this. The pause is the one that I believe is endorsed by ASAM, which is the prediction of alcohol withdrawal severity. I actually have a copy of this pulled up. Let me see if I can share this without making it totally clunky. Let me see here. I had this already pulled up for y'all. Let's take a look. So this is what this looks like. So the pause is a quick screener. Can everybody see the screener okay? Great. Okay. And it's a kind of just a quick screen where there's a max score of 10. And you can see the questions that you go through. Have you consumed any amount of alcohol in the last 30 days? Have you recently been intoxicated? Have you ever had DTs? Those kinds of things. And this can vary a little bit from institution to institution, but generally speaking, if a person's pause score is 4 or higher, that's considered really high risk for complications and withdrawal and may constitute need for an inpatient referral. So in general, we don't use these tools by themselves to guide our clinical decision making, right? But they can help inform us with making the best decision for a patient and meeting them where they are. So pause is one tool you can use. The other tool that I would encourage you to look at if you are somebody who works with people who are doing alcohol withdrawal management either inpatient or outpatient, and that is the CWA, the Alcohol Withdrawal Assessment Score and Guidelines for the CWA or CWA-AR. This is the standard of care for assessing withdrawal. And I will also remind people that it's also useful for helping inform you about intoxication, right? In that, if you think about it, I am seeing somebody for withdrawal from a CNS depressant like alcohol, and then I'm going to tell you in just a minute that the standard of care is benzodiazepines. So you're asking me to give a CNS depressant to a person who is presenting, who has been using CNS depressants, right? And we worry about things like respiratory suppression. And that is why CWA is important. CWA is important for helping you understand the severity of the withdrawal that the person's going through, but it can also help inform you about intoxication and the safety of administering a benzodiazepine. I hope that makes sense. The CWA scoring guidelines, this is very, very helpful. Most institutions use the CWA. I have seen some people do variations of the CWA in ambulatory detox and in inpatient facilities. But what this essentially boils down to is a Likert scale for different symptoms, different common symptoms from alcohol withdrawal. So you'll see that there's nausea, vomiting, anxiety, sweating, tactile disturbances, visual disturbances, headache, right? So these common symptoms, and then they're weighted. So generally what happens is the provider or the nursing staff or the MA will come in and they'll speak with the patient and they'll score this CWA. And this is like golf, okay? We want lower scores. Lower scores means you're doing better, okay? And this is another kind of nuanced part of this. Every institution, every clinic and hospital has slightly different recommendations of what to do based on a CWA score. But in general, when a person's score is 8 or higher, that's when we start administering medications to help reduce the CWA score and reduce the symptoms. So the CWA is really an important component of monitoring the patient and guiding our treatment plan. Let me get my slides pulled back up for you now. Okay. Okay. The other really important part to risk stratification is your clinical history, right? And I've included here some of the most important questions. If these were the only, if I could only ask a few questions, these are the ones that I would ask if I am doing detox, alcohol detox, right? So when was your last drink? One of the most important ones, right? Because of that alcohol withdrawal timeline that I showed to you. What is your drink of choice? And how much do you consume daily? And this is one where you have to ask some follow-up questions for the reason that I outlined for you before. What a person perceives is one drink may not meet the definition of what a standard drink is. And I would argue that this is one of the things that gets us the furthest behind in alcohol withdrawal management is not conceptualizing the use appropriately. Okay. And then what has your past withdrawal been like? Have you ever had DTs? Have you ever had a seizure? And then do you use any other substances or medications, right? There's a host of other things that we would want to know, need to know, but these are some of the most critical questions to be asking when we're doing alcohol detox. In case you're interested, I have hyperlinked that CWA for you on the slide, so you can have access to that if you need it. Let's talk about some of the evidence-based protocols and medications that we can use for alcohol withdrawal. No matter if you're working with somebody on an outpatient basis or an inpatient basis, benzodiazepines are the standard of care. And this is a hill I'm willing to die on. Okay. And that's what I often say to my students. Benzodiazepines are the standard of care. This includes medications like lorazepam, diazepam, clonazepam, chlordiazepoxide, oxazepam. Really, there aren't many differences from a pharmacodynamic standpoint amongst the benzodiazepines. They're all very, very similar. The only difference is in their kinetics, meaning how fast they work and how long they last. So really, you can use any benzodiazepine, but we have some preferences based on those kinetics that I'll talk about now. So on the outpatient side, right, when we're doing ambulatory detox, we generally prefer to use longer acting benzodiazepines. The one that you're probably most familiar with is Librium or chlordiazepoxide. Librium is very useful in that it lasts a long time, and compared to other benzodiazepines, its misuse potential is lower. And the reason for that is not because it's not a benzodiazepine, it is because its onset of action is about an hour, right? So it takes about 60 minutes for Librium to start working the way that it's supposed to. So this is one of the reasons why we like to use it on an outpatient basis. On an inpatient basis, I would make some arguments against using chlordiazepoxide because the idea here is on an inpatient basis, the inference there is, right, is that the patient is sicker, right, and that they may need interventions more that work more rapidly. But we will still use longer acting benzodiazepines on an inpatient basis, but you might see use of something like diazepam or Valium, which is also very long acting, but it also has a very rapid onset of action, and it also offers IV access. So those are the kind of nuanced differences between these medications depending on where you're practicing. On an outpatient basis, generally, the longer acting agents are preferred, especially things like Librium that have a more delayed onset of action. But you could consider, if I have somebody in front of me who's got a really high CWAS score, they're really, really sick. Librium will eventually help them, but I would probably be better served giving them something that works a little bit faster to reduce that score. There are a variety of ways. There are two main ways, really, of applying benzodiazepines to treat alcohol withdrawal, and that can be through a taper, where a person is getting incrementally lower doses day to day, around the clock. And then there's symptom triggered dosing, meaning I conduct a CWA, I look at the score, and if the score is at a certain threshold, I provide a medication intervention. There's also the combination of symptom triggered administration and tapers. Those are the three primary ways. Now, on an inpatient basis, if you have the staff to do it, the symptom triggered protocol is the standard of care. On the outpatient basis, we generally will utilize tapers, both from an adherence standpoint and an ease of use standpoint for patients. Here's an example of a fixed dose taper with chlordiazepam epoxide or Librium. This is a very common outpatient approach where a person will come in and they'll get ordered Librium 25 to 50 milligrams every 6 hours for day one. Okay. And then for day two, we see that interval move to every 8 hours. And then for day three, we move the interval to every 12 hours, right? And then we have a single administration on day 4, 5. Now, this is not just something that we say, here's 5 days worth of medications, go home, we'll see you in 5 days, right? We are still checking in with these folks daily because there may be some instances where I need to repeat day one because they're still feeling really sick, right? So we're going to provide these treatments, and generally the way this works is we will give patients enough medication for a full day, and then they come back to the center or to the clinic for a check-in. You can also use telehealth, and this has got a lot more data behind it since the pandemic, right? Where you're checking in with the patient, you're conducting a CWA, and you're doing a clinical exam to ensure that there's not any worsening of symptoms and that the patient is improving like they're supposed to. I will sometimes get questions about what to do, especially in ambulatory detox, for a person who has liver disease or who is elderly. And it's my favorite, or it's my least favorite answer to give, and it depends, right? It depends on the risk benefit analysis here, right? Where if you have somebody who, if they have significant enough hepatic disease to the point that you're concerned about giving Librium, that patient might be better served inpatient, right? Whereas if it's somebody who has an acute elevation in ALT and AST directly related to alcohol consumption, it's probably not going to be the Librium that's going to put them into fulminant hepatic failure. And I know that feels, I can't be super black and white on this because it does matter on a variety of factors, but it's important to consider the whole clinical picture. And the same thing with elderly patients. I know there are some folks here who work with geriatric patients. This is one of the populations where I've seen some of the most complications from alcohol withdrawal because I would argue because the amount of use was underestimated, and frequently missed. And again, we do have different recommendations for elderly folks because of their more diminished capacity to metabolize medications and renal declines in renal and hepatic function. But again, I would remind you that we are in an acute, serious situation with alcohol withdrawal, and it really requires you to assess the overall picture before you just empirically say, well, I don't want to use Librium because this patient's elderly. I wouldn't take that approach. I would just encourage you to think more about what the best approach would be. Okay. The other option you will see is symptom-triggered lorazepam is a pretty common benzodiazepine used for alcohol withdrawal, although I would argue that maybe it shouldn't always be because of its kinetics and because of how short-acting it is. But it can be useful because it does have a rapid onset of action. So, for example, some of the things that I've seen in ambulatory detox, for example, somebody comes in and they've waited a little too long to come in and they feel really sick, right? So we give them the lorazepam while they're in the clinic to help them feel better. And then we send them home with a taper regimen that they can use at home with Librium, for example. If I were, I don't often see symptom-triggered lorazepam protocols used for ambulatory detox, although you might still see it from time to time. Um, well, the way this works is that you are going to give a dose of lorazepam 1 or 2 milligrams every 4 to 6 hours based on CWA scoring, right? Now, so this really kind of underscores that point about somebody having pretty reasonable health literacy and understanding of the symptoms that they're experiencing and scoring their CWA. Again, I don't oftentimes see this utilized in ambulatory detox. It's going to be more of the former option. But I have seen this on occasion, for example, in elderly patients where you're worried about accumulation with long-acting drugs like Librium. Um, and the other thing that can be consequential here is that there's no active metabolites with lorazepam. Again, that's consequential when you think about drug accumulation. So that could be useful for somebody who does have chronic liver disease from alcohol use or for whatever reason. So there can be some clinical scenarios where you see this utilized, but again, I would not say that this is the preponderance of cases on the outpatient basis. Most of the time, what you're going to see is option number one that I have already showed to you. Some other things that I oftentimes will get questions about are adjunctive medications to use with benzos, and I always start my recommendation the same way, and that is benzodiazepines are the standard of care. Okay. But you can consider some of these other things to help you. Now, things like thiamine are important because folks with alcohol use disorder are, I think, amongst the only people in the United States who are at risk for things like Wernicke's encephalopathy, which is a B1 deficiency. So thiamine administration is totally reasonable. Folic acid is totally reasonable. A multivitamin is totally reasonable. And then encouraging good oral hydration and nutrition and avoiding hypnotics and alcohol. These are very reasonable and evidence-based things to add in addition to those protocols that I already showed you. Some other things though, that I will oftentimes get questions about is, well, what about using anticonvulsants? What about using anticonvulsants either alongside or in lieu of a benzodiazepine? And I want to remind you that even though we are worried about seizures in undermanaged or unmanaged alcohol withdrawal, classical anticonvulsants don't necessarily reliably reduce the incidence of withdrawal seizures or delirium tremens, okay, which is why benzodiazepines continue to be the standard of care. Now, you will see medications like gabapentin used, and there are some reasonable reasons to do that. You could use it as an adjunct to a benzodiazepine regimen, either to try, again, I want to use this language cautiously, to try to have a benzodiazepine sparing effect, but I do want to remind you, like if a patient's scoring on the CWAT and they're sick from withdrawal, you should administer the standard of care. Now, yes, there are some nuance here where you need to make sure that the patient is presenting with both subjective and objective symptoms of withdrawal, right? I'm not just giving medications based on anxiety scores, for example, from a CWA. But I also want to remind you that we don't want to be masking things either with other sedating drugs. We want to be keeping people out of DTs and out of withdrawal seizures. So I think, in my opinion, Where I find gabapentin to be useful is alongside benzodiazepines, um, particularly in the period after they have completed their benzodiazepine taper. Because I think there's like this idea of like, oh, I finished alcohol withdrawal, I'm better now. And that's that's just not the reality, right? When most folks are done with alcohol withdrawal treatment, they still feel really bad. They still have a lot of cravings, they still sleep terribly, and they have high anxiety and all these other things. And this is where, in my opinion, most of the evidence lies, is where you can see some utility with gabapentin in helping attenuate some of those things over time. And I think most of the evidence lies in around 16 weeks, 12 to 16 weeks post completion of alcohol detoxification. But I do want to remind you that this is not something you should be substituting for benzodiazepines. You'll also see questions about carbamazepine or oxcarbazepine. Um, and I'm going to just say, I'll leave it at the data on this are really not that clear. There might be some role for carbamazepine, particularly for people who have benzodiazepine use disorder. But again, I don't think I have enough data here to say that you should be consistently using these as an integral component of alcohol withdrawal treatment. Monitoring and follow-up. So again, we want to be doing daily symptom check-ins. It is reasonable, based on the clinical picture, to incorporate things like telehealth. That is something that is supported by ASAM, depending on the right clinical picture, or having a patient come into clinic to do check-ins. It's important to include the use of a CWA, or some other evidence-based withdrawal scale as a component of your exam. And then it's also important to remember that we are connecting folks to the other services that they need, communication strategies, behavioral health support, motivational interviewing, and peer support. And I also like to point out that, rarely does a substance use disorder occur by itself, right? Like these things just really don't occur by themselves. There's almost always something else going on, whether that's major depression or a panic disorder or, fill in the blank. And so making sure you're actively connecting patients to other treatments that they're indicated for is really, really important, especially from a retention and care standpoint. If you note on any of these follow-ups, clear escalation criteria, again, it's important to have an inpatient referral in your pocket in the case of any of this, right? So if their CWAS score is persistently over 15 in the hospital, most of the time, if a nurse conducts a CWA and that patient's CWAS score comes back over 15 or 16, there's usually a note on there that says like page the attending, right? Because it usually indicates that that patient's really not doing well. Worsening tremor, confusion, hallucinations, seizure activity, inability to adhere to the regimen, right? If they just can't remember or they're just not willing, right? Then they might, or not able, then again, that might be better for an inpatient referral. Or if their vitals are unstable, right? Or if they're presenting and there's a lot of oversedation. Again, these would all be examples of escalation that necessitates an inpatient referral. Okay, so let's go through just some of the key points. So alcohol withdrawal occurs after heavy or prolonged use is abruptly reduced or stopped. There's no such thing as cold turkeying from alcohol. It just doesn't happen. Okay, it does require medical management. And even when somebody generally says that they have stopped drinking cold turkey, what they usually mean is that they've self-tapered. Okay. Ambulatory alcohol detox is a different level of care indicated for people who have more mild to moderate dependence, who generally do not have a bunch of medical complications. We want to be using CWAS, daily symptom check-ins, professional judgment, benzodiazepines, and possible adjunctives to help us. And we really should be conceptualizing this as risk mitigation, not just symptom reduction. And with that, I hope I'm right on time. Thank you all for your attention. I'm happy to have any questions or comments or disagreements on this. I appreciate you guys' participation.
Lucy, thank you so much. Excellent job. Okay, a question from Stephen Flores. Could you recommend naltrexone and or a camprosate?
I love this question. I think there's a little bit of professional preference here. Um, in my days of doing addiction medicine, when you're specifically working with somebody who has alcohol use disorder, um, we don't have the same risks with naltrexone as we do with opioid use disorder, and that we're not worried about necessarily having this like fulminant precipitated withdrawal if we were to give naltrexone. So in my experience, if a patient with AUD expresses interest in naltrexone and or a caprosate, you give it as long as they're medically stable for it, meaning their liver function is intact. And usually what I'll see is towards the end of the detoxification process is when we'll start to offer this. And I know there are some discussion points about specifically the intramuscular depot or oral version of naltrexone. My personal and professional recommendation on this is to consider utilization of the intramuscular formulation because you don't, unlike with antipsychotics, you do not have to have an oral treatment trial with naltrexone prior to administering a depot, meaning you don't have to give the patient oral tablets to test them before you give an IM naltrexone injection. And that's because allergies to opioids and naltrexone are extraordinarily rare. Um, and the other reason is the number one reason patients stop taking naltrexone is because it causes significant upset stomach. And you bypass that with a depot injection. And then with respect to acamprosate, it's the same thing. In fact, um, it's the same thing in that you can start this relatively early. It does work differently than naltrexone. It manages more of kind of the relief cravings that we can see. And there's debate about specifically how it works. The main thing you would want to ensure is number one, that your patient isn't already having a lot of diarrhea and upset stomach because a caprosate can cause that. And number two, that their renal function is intact. And I will also say it is perfectly reasonable to give naltrexone and acamprosate at the same time. And in fact, you probably should if the patient has the right medical criteria for it, because they work differently and they can help manage different parts of alcohol use disorder. And the last thing I'm going to say about this is I spent all this time talking about the meds, but the peer support and behavioral health intervention for this they enhance the efficacy of the drug therapy. And it's really important that the patient be connected to all those interventions.
Thanks, Lucy. Quick question from Nina. Thoughts about adjunctive medications for insomnia during benzo taper?
Oh yeah, okay. So do you mean things like trazodone or mirtazapine? I think I'm going to give an opinion, and everybody's totally welcome to disagree with me. I personally don't favor using things like trazodone. I think it depends too on how the person's CWAS score looks, right? If the only thing they're really scoring on is the insomnia piece, and especially if they have comorbidities like major depression that could be interfering with their sleep pattern, I think it's reasonable to consider use of something like mirtazapine, for example, to help them sleep. Um, it may also be reasonable to consider something like gabapentin, although I would encourage you to talk to patients about that being a holistic kind of intervention, meaning helping numerous symptoms of withdrawal, not necessarily just a sleep aid. Um, and then certainly avoid, I know you know this, Dr. Nina, but just for the group's sake, certainly avoid hypnotics like additional, other benzodiazepines adding to the current regimen that they're on. I personally don't favor using Z drugs like azopiclone or zolpidem, which would be Ambien. I would not advise using things like that. And then the last class I kind of think of are second generation antipsychotics, which are not reasonable selections for primary insomnia. But if your patient has a condition like bipolar disorder or schizophrenia comorbidly, and again, the rest of their CWA is intact, then it might be reasonable to use those as well. I don't personally favor, the other thing you might consider is hydroxyzine, which has some good evidence for things like anxiety and insomnia in this particular context. Um, but outside of that, I can't think of any other meds that I would recommend specifically for insomnia.
Clonidine.
Clonidine. Yeah, I would say I wouldn't personally favor that in this
Okay.
context because I wouldn't want to mask any kind of autonomic disturbance that the patient's experiencing. And I should have mentioned this during the presentation. If your patient is on meds like beta blockers, things like things that end in olol, like metoprolol, for example, that can mask some of those early elevations in heart rate that we look for in alcohol withdrawal. So it's really important to be careful if your patient's on what's called rate control therapy, certain blood pressure medications, because that can kind of hide what we would ordinarily see if they weren't on those medications in terms of a blood pressure and heart rate change. So I personally don't favor use of drugs like guanfacine or clonidine in this for this particular indication.
Did you mention doxepin? Maybe you did.
I did not mention doxepin, and I again, this is 100% my opinion, and I welcome disagreement. I don't personally favor use of doxepin or trazodone or amitriptyline in these particular cases because of their anticholinergic burden. And people sometimes say, well, Lucy, the anticholinergic burden from a 1, 2, or 3 milligram dose of doxepin is different than a 60, 70, or 80 milligram dose that we would use for depression. I'm like, that's true, but it's still very consequential. And especially if your patient is already battling dizziness and autonomic instability, the alpha burden from tricyclic antidepressants, I think there's enough other alternatives that is just not what I would personally favor.
Yeah, now I think I'd plug gabapentin a little bit more in this patient, just because if the case is that you have a patient who's having sleep disturbance after alcohol withdrawal, so I think it's part of the kind of protracted abstinence, then gabapentin I think is going to treat those symptoms well. And then the other thing, the other plug I'd make for gabapentin is I think when we're thinking about patients that have a low risk of a withdrawal seizure and they have mild to moderate symptoms, I think we should all prefer something like gabapentin over benzodiazepine because in the studies where they've compared gabapentin to benzodiazepines, there's a pretty reproducible phenomena of rebound drinking after benzodiazepines, which you don't see with gabapentin or carbamazepine. And so, um, of course, it's not going to stop DTs, it's not going to stop seizures, but you can kind of rule those out with your clinical assessment. So I think using that is a good option for like the right patient population.
Yeah, I generally agree with that. I say especially in the case of like mild case, I think there's definitely compelling evidence for that.
Lucy, thank you so much. We are at time. Great discussion, everybody. Thank you to everyone who chimed in. And Lucy, thanks for being open and doing a great presentation today. These slides are available online. We are going to be back on Thursday, January 22nd from noon to 1 p.m. Just as a reminder, our series now runs from noon to 1 p.m. rather than 12:15 to 1:15. Our presenter is Debbie Thomas. She's the CEO of the Walker Center, and she'll be presenting on updates to the ASAM criteria. We will see you then. Have a great day, everybody.